Welcome. This topic, oral hypoglycemic drugs. Oral hypoglycemic drugs, also called oral anti-diabetic drugs or non-insulin oral anti-diabetic drugs. Diabetes mellitus is a group of metabolic diseases characterized by hyperglycemia. Hyperglycemia results from increased glucose production, decreased glucose utilization, decrease in insulin secretion, or decrease in insulin action, or both. Types of diabetes: we have type 1 diabetes mellitus, that is insulin dependent diabetes mellitus. It may be due to autoimmune or idiopathic. There is a beta cell destruction, beta cell mass less than 80%, and there is absolute insulin deficiency. Type 2 diabetes mellitus, that is non-insulin dependent diabetes mellitus. It is, in this condition, there is insulin resistance, decreased insulin secretion, increased glucose production. Other specific type of diabetes due to other causes: genetic defects in beta cell function, genetic defects in insulin action, diseases of the exocrine pancreas such as cystic fibrosis, and drug or chemical induced, example corticosteroids, in the treatment of HIV/AIDS or after organ transplantation. There may be gestational diabetes mellitus. Beta cell damage of pancreas, and if there is an absence of functioning of beta cells in the islets of pancreas, insulin is given. Secretory defect of insulin can be overcome by giving secretagogues, that is sulfonylureas and Meglitinides. And also we have incretin mimetics, that is DPP4 inhibitors, GLP-1 receptor agonists. The drugs which are helping in the secretion of the insulin, we have sulfonylureas, Meglitinides, DPP4 inhibitors, GLP-1 agonists. Insulin resistance can be reduced by Biguanides and glitazones. These are considered as insulin sensitizers. Glucagon can be suppressed by parenteral non-insulin anti-diabetic drugs, that is Amylin analogs and GLP-1 analogs. Absorption of carbohydrates is hindered by alpha-glucosidase inhibitors. In this category, we have acarbose, voglibose, miglitol. Glucose metabolism irregularities can be corrected by biguanides, sulfonylureas, and glitazones. Combination of drugs, the anti-diabetic drugs combinations of the oral anti-diabetic drug combinations, we have certain advantages. There will be additive effect because of different mechanisms of action, lower incidence of adverse drug reactions of the individual drugs, effectiveness in patients showing resistance to monotherapy, convenience of the administration. These combinations target the primary defects in type 2 diabetes mellitus, that is insulin resistance and insulin deficiency. Coming to the classification of the oral hyperglycemic agents, stimulators of the insulin release by beta cells. We have sulfonylureas, first generation tolbutamide, chloropropamide, second generation glibenclamide, glipizide, glicazide, glimepiride. In Meglitinides, we have repaglinide, nartiglinide. Other category, we have GLP-1 receptor agonist, it is glucagon-like peptide 1 receptor agonist, hexanatide, liraglutide. DPP-4 inhibitors, sitagliptin, vildagliptin, saxagliptin, alogliptin, linagliptin. All these are stimulators of the insulin release by beta cells. Drugs reducing insulin resistance, we have Biguanides, inhibitors of neoglucogenesis, AMP kinase activators. In this we have Metformin and Penformin. And we also have Thiazolidinediones, PPAR activator, also called glitazones, rosiglitazone, pioglitazone. Here we should not confuse with the other antibiotics. We have oxazolidinediones, that is linezolid, which is active against vancomycin resistant enterococci. That is an antibiotic. Oxazolidinedione is antibiotic. Thiazolidinedione here is anti-diabetic. Miscellaneous anti-diabetic drugs, alpha-glucosidase inhibitors, acarbose, voglibose, miglitol, synthetic amylin analog, bromlintide, dopamine D2 receptor agonist, bromocriptine, sodium glucose cotransporter 2 SGL2 inhibitor, dapagliflozin, canagliflozin, sergliflozin. Glucose transporters, we have GLUT1, 2 and 4. GLUT1 basal functions in the basal glucose uptake, present in placenta, blood-brain barrier, red blood cell, brain and kidney. GLUT2 beta cell glucose sensor, beta cells of islets, present in liver, kidney, epithelial cell of the small intestine. GLUT4 insulin stimulated glucose uptake, present in skeletal muscle, cardiac muscle, adipose tissue. Coming to the group 1, stimulators of insulin release individually, we have sulfonylureas, that is first generation. We have tolbutamide, chloropropamide. Second generation, glibenclamide, glipizide, glicazide, glimepiride. The second generation drugs are more potent than the first generation drugs. Coming to the mechanism of the action of the sulfonylureas stimulate insulin secretion from the beta cells of pancreas. That's why we call them as insulin secretagogues. Sulfonylureas bind to the specific receptors on the beta cells of the islets of the Langerhans of the pancreas, bind to the specific receptors on the beta cells of the islets of Langerhans of the pancreas, and They block ATP sensitive potassium channels. Blocking of ATP sensitive potassium channels leads to depolarization. After depolarization, there is influx of calcium ions into the beta cell. Because of the influx of the calcium ions into the beta cells, there is degranulation. And because of this degranulation, there is increased release of stored insulin from the beta cells. Increased release of the stored insulin from the beta cells. For a successful therapy with sulfonylureas, at least 30% functioning of beta cells are necessary. Sulfonylureas are ineffective in type 1 diabetes mellitus because of absence of functioning beta cells in the islets of pancreas. Mechanism of action: same. The sulfonylureas block the sulfonylurea receptor, which constitute a subunit of inwardly rectifying ATP sensitive potassium channel in the membrane of pancreatic beta cells. The inward flow of potassium ions is thereby restricted, intracellular potassium concentration falls, and the membrane is partially depolarized, augmenting calcium channel opening as well as release of calcium ions from intracellular stores. The calcium ions promote fusion of insulin containing intracellular granules with the plasma membrane and exocytic release of insulin. Pharmacological actions of sulfonylureas. Pancreatic action: increases insulin secretion by blocking ATP sensitive potassium channel of the beta cell of the pancreas. Extra pancreatic action: sensitizes target tissue, mainly liver, to the action of insulin by increasing the number of insulin receptors. Modulating post-receptor action on signaling pathway. Inhibition of neoglucogenesis and glycogenolysis. Pharmacokinetics: rapid absorption from the empty stomach. Food interferes with the action of the sulfonylureas, so better they are advised to take empty stomach before food. Peak level is 4 to 6 hours, more than 90% plasma protein bond, mainly metabolized by liver. Chlorpropamine, 20% excreted unchanged in the urine, so it is avoided in the chronic renal failure. Plasma half-life is 30 to 36 hours. 7 to 10 days is required to reach constant plasma steady state. Adverse reactions: hypoglycemia, elderly, in high elderly patients, and this is the most common side effects by sulfonylureas: hypoglycemia. There is a weight gain, also nausea, vomiting, headache, and flatulence may present. Hypersensitivity reactions: allergic reaction, rashes, photosensitivity, purpura. There may be transient leukopenia and agranulocytosis, which is rare. Drug-specific ADRs, by coming to chlorpropamide, may cause cholestatic jaundice, dilutional hyponatremia, and intolerance to alcohol. Tolbutamide reduce the iodide uptake, causing hypothyroidism. Coming to the drug interaction of sulfonylureas: phenylbutazone, cimetidine, warfarin displace sulfonylurea from protein binding, and there is more sulfonylurea action. Chloramphenicol, warfarin inhibit the metabolism of sulfonylurea, so that there is more sulfonylurea in action. Propranolol, theophylline. With sulfonylureas, there is a synergism, so there is more action. Drugs decreasing sulfonylurea action: phenobarbital, phenytoin, rifampicin induce metabolism and decrease the sulfonylurea action. Corticosteroids, diazoxide, thiazide, furosemide furosemide, they decrease the insulin release. Therapeutic uses of sulfonylureas. Type 2 diabetes mellitus. Sulfonylurea responsive patients more than 40 years. Diabetes mellitus of recent onset. No significant ketonuria. Fasting blood sugar less than 300 mg per deciliter. No acute complications. And not for the candidates for surgery. That is not to be given before surgery. And another use is diabetes insipidus. In some conditions, we give in chlorpropamide in diabetes insipidus. Limitations of use of sulfonylureas. We can't use sulfonylureas in type 1 diabetes mellitus. Very long-standing type 2 diabetes mellitus, diabetic coma, diabetes due to pancreatectomy, presence of infection or heavy ketonuria, cannot be used in pregnancy, lactation. Special features of sulfonylureas. Chlorpropamide is the longest acting, glipizide fastest acting, glimepiride stronger extra pancreatic action, glycoside antiplatelet and antioxidant action. Coming to the meglitinides, also called as non-sulfonylureas. In this we have repaglinide, natiglinide. Mechanism of action same as sulfonylureas. Some of the advantages or differences from the sulfonylurea. These meglitinides are rapid in onset, short-lasting insulin release. They better control the postprandial hyperglycemia. There is less chance of hypoglycemia. Side effects: headache, dyspepsia, arthralgia, weight gain is less. Can be given in patients with decreased renal function. Indications: type 2 diabetes mellitus as an alternative to sulfonylureas, or to supplement Biguanides. Glucagon-like peptide, that is GLP-1 receptor agonist, and we also have DPP-4 inhibitors, which act as a incretin-mimetics. Incretins are a group of metabolic hormones that stimulate a decrease in blood glucose levels. Incretins are released after eating and augment the secretion of insulin released from pancreatic beta cells of islets of Langerhans by a blood glucose dependent mechanism. Incretin-mimetics are agents that act like incretin hormones, such as glucagon like peptide 1, GLP-1. So intestinal L cells derive this GLP-1 and GIP. This GLP-1 and GIP are incretins. GLP is glucagon-like peptide. GIP is gastro-inhibitory polypeptide. These two are incretins. These are the gut hormones secreted from enteroendocrine cells into the blood within minutes after eating food. Incretins regulate the amount of insulin that is secreted after eating. Both incretins are rapidly deactivated by an enzyme called dipeptidyl peptidase 4 inhibitors. So, These both incretins are deactivated by an enzyme dipeptidyl peptidase 4. Plant-based meals stimulate incretin and insulin secretion. So the GLP-1 is an important incretin released from the gut in response to the ingested glucose. It induces insulin release from the pancreatic cells, inhibits glucagon release from cells, slows gastric emptying and suppresses appetite by activating specific GLP-1 receptors, which are cell surface G protein coupled receptors expressed on beta and alpha cells, central and peripheral neurons, gastrointestinal mucosa. GLP-1 induces insulin release only at high glucose concentration. The incretin system appears to promote beta cell health as well. Failure of incretins has been implicated in the pathogenesis of beta cell dysfunction of type 2 diabetes mellitus, particularly progression of the disease. GLP-1 based therapy appears to be the most effective measure for preserving beta cell function in type 2 diabetes mellitus. GLP itself is not suitable for clinical use because of rapid degradation by the enzyme dipeptidyl peptidase 4, which is expressed on the luminal membrane of capillary endothelium cells, kidney, liver, gut mucosa, and immune cells. So clinically, DPP-4 inhibitors are come into use as insulin enhancers. Another incretin, glucose-dependent insulinotropic peptide, also induces insulin release. But in humans, GLP-1 is more important incretin, and GIP has poor action in type 2 diabetes mellitus. The GIP receptor is distinct from the GLP-1 receptor, but mediates mostly similar responses. So oral glucose, with help of glucagon-like peptide, that is GLP-1, stimulates insulin secretion, inhibits glucagon secretion, leading to hypoglycemic effect. But this glucagon-like peptide 1 is degraded by dipeptidyl peptidase 4. It causes inactivation of GLP-1. So we have two different drugs, GLP-1 analogs, exenatide, liraglutide, which act like GLP-1, and we also have DPP-4 inhibitors causing reducing the inactivation of GLP-1. Exenatide, synthetic DPP-4 resistant analog, which activates GLP-1 receptors and produces the same responses. It is a source. Exenatide is derived from saliva of Gila monster, which is one type of lizard. Pharmacological actions of exenatide: it is resistant to DPP-4 degradation. Exenatide enhances the insulin secretion, inhibits glucagon secretion, suppress appetite, induce satiety, weight loss, inhibit gastric emptying, stimulate islet growth, differentiation, and regeneration. Subcutaneously in a dose of 5 to 10 micrograms twice daily, 30 to 60 minutes before meals. The T-off is 3 hours. Duration of action is of 6 hours. The most common side effect is nausea and vomiting, for which tolerance develops later. Liraglutide, this is a recently developed long-acting GLP-1 agonist, injected subcutaneously once daily. Half-life is more than 12 hours. Used alone or added to the Metformin or Sulfonylurea or pioglitazone. Adverse effect: nausea and diarrhea are frequent. It is also used as an anti-obesity drug, even for non-diabetics. Hypoglycemia is rare with monotherapy. We have DPP-4 inhibitors, that is sitagliptin, is a competitive and selective DPP-4 inhibitor, which potentiates the action of GLP-1 and also GIP, boost postprandial insulin release, decrease glucagon secretion, and lowers mealtime and fasting blood glucose in type 2 diabetes mellitus. It has no effect on gastric emptying and appetite. Carries the low risk of hypoglycemia unless combined with sulfonylurea or insulin. It is well absorbed orally, largely excreted unchanged in the urine. Dose reduction is required in renal impairment. Half-life is 12 hours. Adverse effects: is well tolerated. Nausea, loose stool, headache, rashes, allergic reactions, and edema. Nasopharyngitis and cough occur in some patients due to prevention of substance P degradation. Vildagliptin, which binds to the enzyme covalently. It is also DPP-4 inhibitor. The complex dissociates very slowly, resulting in persistent DPP-4 inhibition even after the free drug has been cleared from the circulation. This explains longer duration of action, 12 to 24 hours, despite of short plasma of life of 2 to 4 hours. Major route of elimination is the liver metabolism. 20 to 25% is excreted unchanged in the urine. Dose reduction is required in moderate liver and kidney diseases. Tolerability similar to sitagliptin, but hepatotoxicity has been reported. It may require twice daily dosing, though single daily dosing suffices when combined with another hypoglycemic agents. Saxagliptin, like vildagliptin, it also binds covalently with DPP-4 and acts for 24 hours, despite a plasma half-life of 2 to 4 hours. Drug interactions with CYP3A4 inhibitors is possible. It is taken 5 mg OD, reduced by half in moderately severe renal failure, but not in liver disease. Alogliptin and linagliptin are very long-acting gliptins. So, secretive drugs, under secretive drugs, as we have the drugs which help in secretion of insulin. We have sulfonylureas, Meglitinides, GLP-1 analogs, DPP-4 inhibitors. Then coming to the drugs reducing the insulin resistance, inhibitors of hepatidioglucogenesis. In this we have Biguanides, Metformin, Penformin. Mechanism of action: inhibit hepatic neoglucogenesis, increases peripheral glucose utilization, interfere with mitochondrial respiratory chain, enhance anaerobic glycolysis, promote peripheral glucose utilization. So metformin inhibit readily intestinal absorption of glucose and other exosomes, and also inhibits vitamin B12 absorption. This Biguanides acts as insulin sensitizers in the muscle and adipose tissue. Enhance insulin-mediated glucose disposal in the muscle and adipose tissue by GLUT4. Enhance GLUT1 transport from intracellular site to plasma membrane. Promotion of insulin binding to it, receptors. Additional effects: total cholesterol, LDL, triglycerides are decreased. Plasma fibrillary activity is increased. Lipolysis is decreased. Lipid oxidation is decreased. Appetite is decreased. Adverse drug reactions: there may be unpleasant bitter metallic taste with metformin, anorexia, nausea, abdominal discomfort, tiredness. Lactic acidosis, the most serious complication, is more common with metformin. May be lethal during acute illness like severe infection. So nowadays we are not using metformin. The only biguanide we use is metformin. And also it causes, biguanides causes vitamin B12 deficiency. Contraindications of metformin: we should not give when there is liver disease, when there is a chronic kidney disease with serum creatinine more than 1.4 mg per deciliter, chronic obstructive pulmonary disease, congestive heart failure, and chronic alcoholism. There are special precautions you advise when you start the biguanide therapy, that with metformin therapy. We should always assess the elderly patients before giving the metformin, assess the renal function before prescribing the biguanides. We should omit metformin before major surgery. The surgery is planned, so we should stop the metformin therapy for the patient. Patients undergoing radiocontrast study also, we should omit metformin before and 48 hours after the procedure. Therapeutic uses of metformin: obese, type 2 diabetic mellitus patients. Secondary sulfonylurea failure. Polycystic ovarian disease, PCOD. Metformin decreases the insulin resistance, regulates the menstrual cycle, causes ovulation, and also it helps in weight reduction. There's a condition called non-alcoholic steatohepatitis, NASH. There is increased insulin resistance is the major pathogenic mechanism in the development of non-alcoholic steatohepatitis. Improvement of insulin sensitivity with metformin may improve the liver disease in patients with NASH. Metformin started with 250 mg 2 to 3 times a day with major meals. Gradually increased up to 2 grams per day. The important difference between the sulfonylureas and biguanides: sulfonylureas causes hypoglycemia. Biguanides does not cause hypoglycemia. Coming to thiazolidinediones, glitazones. I already told you, don't confuse with or antibiotic which belongs oxazolidinedione, that is linezolid, that is antibiotic. Here this thiazolidinedione is anti-diabetic. It is all glitazones come under this thiazolidinediones: troglitazone, rosiglitazone, pioglitazone. Glitazones are the selective agonists of PPAR gamma receptors, that is peroxisome proliferator activator receptor gamma receptors, and they modulate gene expression involved in glucose lipid metabolism, insulin signal transduction, adipocyte differentiation and proliferation. The glitazones increase insulin sensitivity, activation of PPAR gamma in adipose tissue, reduces the flux of fatty acids into muscles, thereby lowering insulin resistance. Stimulation of glucose transport into the muscle. There is activation of adiponectin, and there is increased AMP kinase, stimulate glucose transport into the muscle. Stimulates GLUT4 expression, increase glucose uptake via transporters. Reduce hepatic glucose production by inhibiting neoglucogenesis. Lowers glycosylated hemoglobin HbA1c. Plasma free fatty acids are decreased. Triglycerides are decreased. HDL is increased. So, but there is a weight gain with glitazones because of proliferation of new adipocytes, increase in the subcutaneous adipocyte mass, and divert triglyceride storage from visceral adipocytes to subcutaneous adipose tissue. There is a redistribution of fat store. Glitazones have anti-atherosclerotic action, decrease the production of inflammatory cytokines, TNF-alpha, interleukin beta, decreased vascular smooth muscle proliferation. Pharmacokinetics, maximum clinical effect after 6 to 12 weeks, contraindicated in active hepatic disease, prescribed once daily. Adverse drug reactions, there is a hepatotoxicity seen with troglitazone, rosiglitazone, and these two are withdrawn from market because of hepatotoxic potential. Pioglitazone has lesser toxicity, but the regular liver function test is advisable. There is a fluid retention, increased fluid retention and the plasma volume, and there is weight gain due to proliferation of new adipocytes, redistribution of fat store, and fluid retention. Non-specific, there is headache, myalgia, and anemia. Therapeutic uses of glitazones, type 2 diabetes mellitus, other insulin-resistant cases, non-alcoholic steatohepatitis. Coming to the miscellaneous anti-diabetic drugs. In this we have alpha-glucosidase inhibitors, acarbose, oglibose, Meglitinides. Here the carbohydrate is converted into absorbable monosaccharides by alpha-glucosidase enzyme. And this alpha-glucosidase can be inhibited by acarbose, oglibose. The acarbose binds completely to carbohydrate binding sites of alpha-glucosidase enzymes in the brush border of the enterocytes of the jejunum. Acarbose binds completely to the carbohydrate binding sites of alpha-glucosidase enzymes in the brush border of the enterocytes in the jejunum. Acarbose thus inhibits the absorption of carbohydrates but not of glucose, because acarbose does not interact with the intestinal sodium dependent glucose transport. So acarbose and oglibose are common in use. These don't stimulate insulin release and therefore does not cause hypoglycemia. Postprandial plasma glucose level decrease in both diabetic and normal individuals. Regular usage tends to lower HbA1c, body weight, and serum triglycerides. Adverse effects of the alpha-glucosidase inhibitors. There may be flatulence, abdominal bloating, discomfort, diarrhea, elevation of liver enzymes. These alpha-glucosidase inhibitors nowadays most commonly used are acarbose and oglibose. We give along with other hypoglycemic drugs or insulin. Acarbose is a oligosaccharide of microbial origin and causes elevation of liver enzymes. Glipose has similar properties, uses adverse effects similar to that of agarmose. Dose 200 to 400 mg TDS before meals. Miglitol is less hepatotoxic. Then coming to the synthetic amylin analogs. Pramlintide. Effect of amylin on glycemic levels. Amylin is a polypeptide. It is co-secreted with insulin. The decreased endogenous glucose production, especially postprandial, induce centrally mediated satiety, opposing action of ghrelin. Controls postprandial hyperglycemia. Diabetes mellitus, amylin levels decreased, but we cannot go for amylin replacement because plasma life of amylin is very short. So synthetic amylin analog pramlintide is used. Pramlintide is indicated when postprandial hyperglycemia is difficult to control. It also decreases weight. It is given subcutaneously thrice daily along with insulin before meals. Adverse drug reactions and increased frequency of hypoglycemias, nausea, vomiting, anorexia, and there is early satiety. Miscellaneous anti-diabetic drugs, we also had dopamine agonist, that is bromocriptine. It's a oral formulation used as an adjunctive in the treatment of type 2 diabetes mellitus. Taken early in the morning, it is thought to act on the hypothalamic dopaminergic control of the circadian rhythm of the hormone, growth hormone, prolactin hormone, adrenocorticotropic hormone release, and reset it to reduce insulin resistance. Bromocriptine can be taken alone to supplement diet and exercise, or added to the metformin or sulfonylurea or both. Started at 0.8 mg OD and increased up to 4.8 mg OD, has shown improved glycemic control and lowers HbA1c up to 0.5%. SGL2 inhibitors, that is sodium glucose cotransporter 2, that is SGL2 inhibitors. In this we have dapagliflozin, canagliflozin, sergliflozin. Mechanism of action: the kidney continuously filters glucose through glomerulus, and nearly all of this glucose is reabsorbed back from the proximal tubule by a transporter called SGL2. The glucose is reabsorbed back from the proximal tubule by a transporter called SGL2. Inhibiting SGL2 cotransporter decreases the amount of glucose reabsorption from the proximal tubule and increases its excretion. So SGL2 inhibitors, dapagliflozin, sergliflozin inhibits the SGL2. So there is no glucose reuptake in the proximal tubule. Advantages: causes weight loss, no hypoglycemic episodes as they are excreting only the excess of glucose from the blood, not inducing insulin secretion. Improve insulin resistance, beneficial in patients of diabetes mellitus with hypertension due to their diuretic effect. Disadvantages: because of polyuria, that is glucosuria, there would be more polydipsia, increased risk of urinary, bacterial, or fungal infection in the presence of glucosuria, risk of sodium